Hello everyone, this is the Dr. Sudan Rao on the program I Teach Medical Students. In this class, we are going to touch briefly on the diagnosis and treatment of sickle cell disease, part 2. In part 1, we already touched on the definition, pathophysiology of sickle cell disease, including clinical manifestations. In this part, we are going to briefly discuss about diagnosis and treatment of this chronic hemolytic anemia. Diagnosis, which includes clinical features and laboratory workup. In laboratory workup, we touch on the complete blood counts, sickle test, hemoglobin electrophoresis, blood culture, serum bilirubin, X-ray chest, complete urine analysis, other investigations based upon the presentation. Coming to clinical data. This disease is characterized by progressive anemia with onset around later infancy. There will be a history of recurrent respiratory infections with wheeze. This is the characteristic feature in the clinical data. Dactylitis, which is symmetrical painful swelling of the joints of the feet as well as the hands in infancy. Splenic sequestration is a dreadful complication of sickle cell disease presenting with volume depletion and hypovolemic shock. Sickle pain, aplastic crisis, hemolytic crisis, and history of recurrent blood transfusions. These are the clinical data that should be taken into consideration in the history. In suspected cases, the newborns must have undergone a screening test, which will give you the clue that the baby is going to have sickle cell disease. FS pattern supports HBSS disease. If the hemoglobin electrophoresis shows FS pattern, presence of fetal hemoglobin and sickle hemoglobin, no adult hemoglobin at all. This supports presence of HBSS. FS is seen in sickle thalassemia. That is, HBS is around 50%, HbA2 is more than 3.5%. This gives you the clue the patient may be having sickle thalassemia. FAS pattern supports sickle cell trait, that is, fetal hemoglobin is the highest, followed by adult hemoglobin and a small amount of sickle hemoglobin. This suggests of sickle cell trait. Pattern of AFS. This is seen in post-transfusion neonates with sickle cell disease. Here, HbA is more than HbF or HbS. Coming to the lab profile. In this, we are going to consider blood counts, peripheral smear, other biochemical workup before we proceed with the therapeutic considerations. What is the significance of taking hemoglobin? Hemoglobin should be checked to confirm presence of anemia and should be maintained around 10 grams per cent in order to avoid some of the complications associated with sickle cell disease. It falls down below 2 grams per cent in splenic sequestration. In aplastic crisis, results in sudden fall of hemoglobin. And low hemoglobin is a risk factor for stroke. It is the cause for growth failure. It complicates bone marrow hyperplasia, contributes tissue hypoxemia. That is, contributes to tissue hypoxic damage. When the oxygen carrying capacity is low due to fall in hemoglobin, there is hypoxic damage to the tissues. Blood counts. What is the significance? RBC count is usually elevated because of erythroid tissue hyperplasia. PCV, MCV, MCHC are normal ranges. WBC elevated, it is a risk factor for silent cerebral infarcts. Platelet count is usually elevated, and a sign of hypercoagulopathy should be kept in mind. It should be brought to normalcy with treatment. It is a risk factor for stroke. Reticulocyte count, elevated in all the situations except in aplastic crisis. Coming to peripheral smear, it is normocytic, normochromic. There will be presence of sickle cells, target cells, and whole jelly bodies, indicating a functional asplenia. Coming to the biochemical aspect of laboratory profile. Serum bilirubin is usually elevated due to the increasing hemolysis. Liver enzymes are usually normal except in sickle hepatopathy. Alkaline phosphatase is elevated in sickle intrahepatic cholestasis, which is irreversible. Serum haptoglobin and hemopexin levels are low. Serum hepcidin level is elevated. So it is associated with disturbed iron profile. Urine, there is microalbuminuria, microscopic hematuria, and hypostenuria, indicating renal parenchymal damage. Then let us proceed with the therapeutic considerations. What is the plan of treatment for the child with sickle cell disease? There is hydroxyurea, should be started as early as possible. Folic acid supplementation at the rate of dose of 5 milligrams per day. Then penicillin prophylaxis, it should be started as early as from infancy. A dose of penicillin V 250 milligrams BID. You should immunize the child against capsular bacteria like pneumococcal vaccine. Then hemopoietic stem cell transplantation, allogenic matched sibling for HSCT. Red blood cell transfusions. They could be episodic in acute emergencies like sickle cell sequestration or the plastic crisis, or could be regular in order to maintain the hemoglobin level around 10 grams per cent. When there is iron overloading during regular checkup, the iron chelation has to be treated in the children, especially who are on regular transfusions. They are the children at risk of developing hemochromatosis. Then coming to hydroxyurea. It is the mainstay in the treatment of sickle cell disease. It is the modifier of fetal hemoglobin. It is used as immunosuppressant drug. It is hemoglobin, fetal hemoglobin gene inducer. Induces HbF levels, improves hemoglobin levels, improves red cell hydration, okay? Reduces the degree of hemolysis, reduces cytoadhesiveness. This is a very important factor. It results in elevation of hemoglobin F levels. Okay, it reduces oxygen delivery, reduces leukocyte count. It is a beneficial effect. It reduces platelet count, increases erythropoietin levels, improves nitric oxide level. Okay, that results in the vasodilatation, decrease LDH levels, and it reduces the frequency of blood transfusions, okay, in a child with sickle cell disease. Ultimately, overall survival time is improved in the patients with sickle disease who are treated with hydroxyurea. What is the protocol? Start as early as possible, around 9 months of age, at a dose of 15 milligrams per kg per day in OD dose. The follow-up should be done at 2 weeks intervals, okay, for about 3 months. Step up the dose to 20 milligrams per kg. Okay. Follow up every 1 month for 3 months. Okay. Step up 25 milligrams per kg if response is inadequate to a maximum dose of 35 milligrams per kg per day. So progressively step up the dose and monitor the results with regard to the hemoglobin level, HbF level, and during each visit. And also monitor the mean corpuscular volume. So what are the indicators of good response? Rising HbF level more than 20%. Okay. If baseline HbF is very low, the response is good. Well, there should be rising MCV more than 100 with regard to the good response to hydroxyurea. You have to target these values while the patient is on hydroxyurea. But stop hydroxyurea if one of these things are present. Leukocyte counts falling below 2,500, there's falling platelet count, and fall in the hemoglobin less than 5 grams. Hydroxyurea has no effect for nephropathy, okay, TRV, that is tricuspid jet velocities, and it is no effect on the silent cerebral infarcts. There is always a risk for developing male infertility. So other drugs that are used in the treatment, medical management of sickle cell disease are glutamine that improves pain crisis, modest effect on the acute chest syndrome, no effect on rate of hemolysis. The same way, crizanlizumab, no effect on hemolysis, but improves crisis. Recent drug, Vaxalator, a hemoglobin oxygen affinity modifier, reduces hemoglobin polymerization, reduces hemolysis, improves tissue oxygen delivery. This is a drug that recently approved by FDA. It is not available in all the centers, but if available, so it is a better option for the treatment of sickle cell disease, and it is the gold standard treatment for these patients to improve the, quality of life. In general, the steps of approach to the patient with sickle cell disease are as follows. Symptomatic, that's giving the pain relievers. Supportive, give the folic acid, other vitamin supplementations. Preventive, provide immunization. Abortive, to the acute management of the crisis situations. And curative, in terms of stem cell transplantation. Thank you with a smile. Thank you very much for patient listening. We'll meet you again in the next time. Until that time, bye-bye.